guys. As you all know, I'm Eliana. I was at Hewlett in Long Island. My special case was a 90-year-old female who came in for left knee pain. The patient was ambulatory. She was able to walk, although she did have some pain when walking. She was an average-sized patient, stenic, and was pretty mobile for her age. I was actually pretty surprised. But she did have some pain. Now, the clinical indication was for left knee pain, and I asked her what brought her in, and she explained that she had fallen the night before. She fell face down, or face first, forward onto the floor from tripping, and injured her left knee. She explained to me that she didn't have any specific area of more pain in the knee, just a more general pain and discomfort around the whole joint. She also experienced pain when going from a sitting to standing position, and she also experienced pain and discomfort when walking and weight bearing. For these reasons, I decided to do the exam on the table instead of weight bearing, because I felt that the lateral would be a little bit too difficult for her and too painful. So we did it on the table. We did the routine AP, sunrise, and lateral views of the knee. The AP was pretty standard. I used 60 kVp at 4.5 mass. Then I moved on to the sunrise, which was a little bit more difficult and painful for my patient, because in the room that I was in, it requires the patient to have to flex the knee more. And with that flexion, she had some pain and discomfort. So I tried to work very quickly to get her out of that position as quickly as possible. Next, we did the lateral. She was able to roll onto her side pretty well, actually, and had some pain when bending the knee, but not as much as she did with the sunrise. After that, the patient left, and I was able to look at the radiologist report to see what he found in the radiographs. Now I have that here, and I'm going to read it because it's lots of words. The findings in the radiographs are degenerative joint disease in the left knee with moderate medial joint space narrowing and large tricompartmental marginal osteophytes, which I will get into in a minute. There's also moderate knee joint effusion as well as osteopenia. None of these are related to the trauma that she experienced. There is no acute fracture or dislocation in the knee, but there's a lot of pathology going on that was pre-existent. Before we look at the radiographs, I'm going to talk to you guys a little bit about osteoarthritis.
Degenerative joint disease is also known as osteoarthritis. It's the most common joint disease and is characterized by chronic gradual degeneration of the protective cartilage covering the bones of a joint. The cartilage flakes or crevices, and with time, the cartilage of a joint can be lost. And so in later stages of arthritis, there is a lot of bone-on-bone articulation, which is painful for the patient. Now, there are several stages of osteoarthritis in the knee joint. As you can see, in the first model on the left-hand side is a normal knee joint. The second one to the right of that represents the first stage of osteoarthritis, which is mild. Bone spurs form and the cartilage remains intact. The joint space is normal, and so is the mobility, but the patient may experience some pain after walking or running, or tenderness in the knee when bending or kneeling. Now, the second stage of osteoarthritis is the moderate stage, and this is the third model. Damage to the cartilage is now present, as you can see in the red areas that represent joint cartilage erosion, and the joint space also narrows. The patient has pain when running or walking and is accompanied by swelling. The patient also experiences pain when bending or kneeling, and there's joint stiffness when going from a sitting to a standing position or when waking up in the morning. So after not using the joint for a while, the patient may experience pain. Now, the final stage of osteoarthritis, which is the model all the way to the right, is the severe stage. The joint space dramatically reduced due to the loss of most, if not all, of the cartilage. As you can see, there's far less blue cartilage in the last model as compared to the first few models. There is also a loss of joint space, as you can see, in between the two bones, the femur and the tibia. The joint is very stiff and possibly immobile, and the patient has a lot of pain when walking or moving the knee. So in patients with severe osteoarthritis, you have to be careful when moving the joint. Now there are three compartments of the knee joint. The first is the medial tibiofemoral compartment, the lateral tibiofemoral compartment, and the patellofemoral compartment, as seen in these two images here.
Okay, as you can see, this is the AP radiograph of the knee. First, I want to talk about the positional errors. Here, we see that there is lateral rotation as evidenced by the fibular head being more superimposed by the tibia, as well as the patella being free of some superimposition on the lateral side. So, what I should have done for this radiograph is to check the borders of the patella to make sure that they're centered over the femur. But the tech did take this radiograph because the joint space is open. Now, we do see evidence of osteoarthritis. Clearly, the joint space is narrowed a little bit more so on the medial side as well as in the center and on the lateral side. You also see osteophytes. Now, osteophytes are also known as bone spurs, which are bone growths along the joint margins. So this means along the edges of the joint. These are evident in the distal femur, here, all through here, and you can see a pretty decent sized one on the lateral side there. They're also evident on the tibia as well, a lot on the eminence in the center, and on the lateral side here. Another pathological condition in this radiograph is osteopenia, which is decreased bone mass or density, not quite to the point of osteoporosis, but it can lead to it, and this is evident in the proximal tibia just around the head of the fibula here. Next, I want to move on to the sunrise. The most evident pathological process here is the patellar enthesophytes, which are abnormal bony projections at the attachment sites of tendons or a ligament. Now, these can't be confused with osteophytes because this is where the tendon attaches, the patellar tendon, on the anterior surface, and as you can see, the bony projections along that surface there. We also see some degeneration of the joint space because it is partially closed, but it's difficult to tell because there are a lot of osteophytes in that joint area as well. Next, we're moving on to the lateral. Here, I want to talk about the rotational errors first. It's a little bit difficult to see the rotational errors because there is so much bone growth, but as you can tell here, the epicondyles aren't completely superimposed, and by the evidence of the adductor tubercle posteriorly, this means that there was not enough rotation. This is also evidenced by most of the fibular head being superimposed by the tibia. So I should have rotated the patient more laterally. Osteoarthritis is hard to evaluate in the joint space because of the rotational error and because there's so much bony processes going. But you can see that it's pretty small, the joint space here, and you can't really define the joint space between the femur and the patella. Another pathology that the radiologist discussed was joint effusion. Now, this is evidence from fat pad separation side, which is here, just above the patella, and just anterior to the distal femur. This is also evidenced by a round, soft tissue density just above the patella, as you can see right here. Joint effusion is a little bit more difficult to define in radiographs, but I think this is it here. Osteopenia is also evident on the anterior surface of the proximal tibia, just here. So you can see it's a little bit more density in this area, or I guess less bone in this area here. So what I could have done for the lateral is increase the technique to make up for the added densities around the joint space so that we could see the outlines a little bit clearer.
So, what did we learn from all of this? First of all, I wanted to think about what I should have done or could have done with this particular patient. I could have been more conscious of joint disease. Because this is a geriatric patient with joint pain, it should have tipped me off that it could possibly be a joint disease. I should have taken a more thorough medical history, which would have changed how I manipulated the patient, and I also could have changed how my patient care after seeing the AP radiograph of the knee, seeing that there was a pathology present. And I also could have adjusted my technique from the AP to the lateral, increasing the technique because of the added density. In the future, I have to remember that just because a patient comes in for a simple fall, it doesn't mean that there isn't an existing pathology present. So, and it's important to continue to take the history throughout the exam. So, for example, in this situation, when I noticed that there was a pathology present, I should have asked the patient if she had a history of osteoarthritis, which would help me in my patient care as well as adjusting my techniques. And by being aware of and understanding the signs and stages of osteoarthritis, I can adjust these techniques. First, in the early stages, I can increase the technical factors because of the added density due to bone spur growth. And I also know in early stages that the patient will be a little bit more mobile, whereas in the more later stages of osteoarthritis, the patient will be less mobile, and I'll know to decrease the technical factors because of the decreased density in the joint area. I hope you guys have learned something from my presentation today. Thank you for listening.